Okay. Okay, so this evening we're going to look at MR-guided radiotherapy, and that's a bit of a slightly misleading title there, in the sense that we're not going to look at the whole scope of MR-guided radiotherapy. I'm going to talk purely about MR-guided treatment units, and so hopefully you're all excited about that, and you're all relaxed, and you've got your cup of tea or your glass of beer or a glass of wine. As you can see, I've got all three ready to go. So let's crack on. I think probably a good place to start is to start with a bit of a disclaimer, and that is I have not seen an MR-Linac, nor have I seen another MR-guided treatment unit. But I would be quite surprised if there's anyone else in this webinar this evening that has. Okay, yeah, neither have I. Anyone here tonight seen one outside of a presentation? No. No, and that's not unexpected from my perspective. I think in the UK there are, I think, 2, maybe 3 centres that are in the process of installing MR-Linacs. There's the Royal Marsden and there's the Christie. I'm not sure if there's anywhere else. Correct me if I'm wrong. Somebody else might know. If anyone else knows of anywhere else in the UK that is, please say so. In North America, there is an MR-guided centre in the Princess Margaret Centre in Canada. I think there are 3 or 4 centres in the US with the ViewRay System, which I'll talk about later. And clearly in Europe, most of the MR-Linac stuff came out of research work in Utrecht. And so in the Netherlands, they're sort of a bit of ahead of the game, but they're quite rare. And there's, as we'll see, there's quite limited clinical data. So I suppose I should say as well that in some of the stuff that I put in the workbook page on MR-Linacs, MR-guided treatment units, I said there was very little published data. That's not quite true. There's been published work since about 2005 on the feasibility of MR-guided treatment units, but there is virtually nothing on clinical data on the actual use of these treatment units in practice. So a lot of this stuff is still fairly new to everyone in the radiotherapy field. In fact, if anyone has seen some of the very early work that was published on the feasibility of this, you'll see, this is in Utrecht, you'll see that they tested the feasibility of synchronous MR imaging and Linac delivery on pork chops. And there's actually a couple of really good images that show that of 2 pork chops with and without the Linac on, and it shows how good it is. Okay, let's crack on with this. So as usual, the first sort of half an hour or so of this evening is dedicated to the presentation, and then we will engage in some discussion. But please do type away. If you've got questions, then type as we go. I'll try and keep an eye on them. At the moment, we've not got too many people in the chat room. But if you've got questions, go ahead and ask them. I'll try and keep an eye on it and answer as we go. Okay, so where to start? Well, firstly, we should say that the use of MR in radiotherapy is not new. I think we all know that. We've established that in earlier parts of this course, but we know the benefits, and these are well established. Primarily, these relate to the fact that we have no ionizing radiation, and more importantly, the fact that we get superb soft tissue contrast that we don't get with CT. And this is sort of underpins the potential of an MR-guided treatment unit. The fact that we can see soft tissues much better than we can with cone beam CT or megavoltage CT. So what we've got on this slide is some data from some work of, this was, again, comes from Utrecht, Ellen Kirchhoff and Bas Raymakers, who do a lot of the early work on the development of a prototype MR-Linac. And what we looked at here, this wasn't an MR-Linac, okay? This was purely about looking at the potential for MR in radiotherapy. And so this looked at doing repeat MR scans for radiotherapy patients during treatment. So there was a pre-treatment MR and then weekly MR scans during radiotherapy. And what we can see on here is an illustration of why there is a potential benefit of using MR as a guidance for our delivery. And what you can hopefully see is that if we look at the pre-treatment, let me try and get a little arrow on here. If we look at the pre-treatment MR scan on here, you can see in yellow the cervix, the uterus and the cervix outlined on this MR scan. And then if you look at, and again, I'll try and use a different marker on here. Let's use this one. If we look at all of the other scans that we can see on here from weeks 1, 2, 3, and 4, you can see how the volumes in green, red, blue, and light blue vary quite considerably. So if you look at the right-hand side here with the overlay, you can see a massive difference in the size, the position, the shape of our clinical target volume based on an average of these 11 cervical cancer patients. So this was and the images at the bottom here are quite slightly less important. They sort of illustrate what's been outlined. We can see in blue down here our CTV. We can see the rectum in yellow. That's probably the bladder in pink. Bowel in green, and yellow is probably a nodal area. From what I can recall from this paper on the left-hand side, there will also be a nodal area on the right. So we've only got one slice on this MR scan here. And again, we can see in sagittal section here on the right-hand side how these different volumes vary from week 1 to 4 here, illustrating the potential need for good soft tissue imaging during radiotherapy. And you can probably see how this might not be feasible. You wouldn't see this sort of level of detail using cone beam CT. If you think we can, then type away and sort of try and illustrate how we could do that. Another benefit here, again from the same paper by Ellen Kirchhoff, was they looked at and what we've got here is V10, V20, V30, and so on. Percentage volumes irradiated for different organs at risk. So we've got bladder, rectum, bowel, and sigmoid colon here. And what we can see on this slide is in establishing from the pre-IMRT and then looking at the difference between that and the online IMRT, so these were the ones that were taken week to week, how much different these volumes were, these dose parameters were at all these different dose levels here. And where there's a star, you can see there is a statistically significant difference. Okay, some of these are quite small, and you would argue whether they are clinically important. So, for example, here, and there are probably a few more on here as well. Even these ones might, and certainly that one might be considered to be clinically unimportant. But there are also some ones that are very big. So if we look at here, and then again here, and certainly as we go through, as we get towards these higher dose levels, these are all very, very significant differences and show the value of using online MR guidance. And bearing in mind this is for a particular category of patients. These are all cervix patients. So this sort of established how valuable this MR guidance could be. And again, this is other research that came out of the Utrecht Centre. Again, Ellen Kirchhoff here leading on this. This was, again, this isn't MR-guided radiotherapy. This is just looking at daily MRI for a series of healthy volunteers. And what we can see on here, as I'm sure you're all familiar with prostate patients, the impact of variation in rectal volume and the impact of moving the prostate around. So we can see this is this is just one example of one patient, and you can see variations throughout. MRI images taken on different days, and you can see if you look at the comparison of the rectal volume on all of these, going from small to large, it varies very significantly, and you can see the impact of this on the size, the shape, and the position of the prostate. And on the right-hand side here, what you can see on this little chart is an indication of the extent of how much the movement of the prostate will impact on the dose to the anterior rectal wall. So on this axis here, we've got a fractional dose difference for the anterior rectal wall, and on this axis we've got the deformation of the prostate. So as the prostate is deformed, and this is in millimeters, you can see as if this is deformed up to 3 millimeters, we're seeing fractional differences in the dose to the anterior rectal wall in the region of 12 to 15%. That's very significant. And you might appreciate this, you might be aware of this, but MR demonstrates it beautifully. And it's sort of a very good way of sort of illustrating the potential benefit of using daily MR guidance for certain categories of patients. So far we've been able to see that for cervix and for prostate in feasibility studies before we've even got MR-Linacs. So, and that begs the question, what if we can combine a linear accelerator and an MR scanner? But of course there are a whole host of fairly major technical challenges that need to be overcome. Both the physics of MRI and the physics of linear accelerators sort of contradict each other in a number of important ways. And so we need to be aware of such things as, well, how are we going to be able to deliver radiotherapy through an MR magnet? That's a major technical challenge. So how can we achieve that? We've got issues of, well, we need some sort of, with MR we use radiofrequency coils, antennas. They need to be radio transparent. The fact we need to be aware that the magnetic field will have an impact on the production of secondary electrons, and that, as we'll see in subsequent slides, that's going to have a major impact at particularly where there are tissue-air interfaces, and that includes skin dose, so entrance and exit doses, and that has a major impact there. And there are also issues with such things as, well, radiofrequency interference. We typically, MR scanners on their own, if we look at just an ordinary MR scanner, they're situated in a room within a Faraday cage, and the purpose of the Faraday cage is to minimize the influence of radiofrequency interference. But you can't really do that in an MR-Linac or MR treatment unit. If you've got an MR-Linac, you have to sort of think, well, how can we can't put everything in an MR cage, in a Faraday cage. We have to be able to sort of separate out the MR scanner and the Linac because they do interact with each other. So there's some major challenges to try and overcome. So I'm going to skip over this. I've already talked about this, and I can illustrate this on some subsequent slides. So here we go.
what we can see on this slide, it looks very complicated, but it's not really. And again, work coming out of Utrecht. They've done all of this in their research centre there. What we can see on here is, if you look at the right-hand side, that's probably the easiest, well, probably the middle one's easiest to interpret. You can see we've got tissue, air, and tissue, and then exit dose at the back here. What you can see is that with in an MR LINAC scenario, we have a quite big increase in dose around this tissue-air interface here. And again, we see an increase in dose at the exit point just here. And that's mirrored on the image on the right. So you can see here, this compares with the solid line represents the dose profile in a 1.5 Tesla magnetic field, and the dotted line represents what we would have without any magnetic field. So that's what you would see. The dotted line is what you would see with an ordinary LINAC, and that's what you'd expect. Okay, so that's modeled very well. But what you see with the MR LINAC is this big increase in dose at this tissue-air interface here. This change in expectation here, and again this increase in dose at the exit point here. So these are fairly major considerations as a result of the electrons being attracted back to the secondary electrons being attracted back to the magnet. That's what happens here. You get lots of secondary electrons produced here, and they're all being attracted back to this main magnetic field. Another example here of this issue is skin dose, and it's highlighted at the bottom. So as you can see here, you can see there is it's a fairly small, but it's a noticeable difference in skin dose where we've gone from treatment with, we can see here, 0 Tesla. Here, this is for whole breast irradiation with 2 fields, whole breast irradiation with 7 fields here. So 2 different techniques, and we're moving from 0 Tesla to increasing field strength. And you can see down here how that increases the dose to the skin. So it looks quite small, but it's very significant. It's certainly statistically significant, this increase, and it may be of concern in how we plan and have to care for certain patients. So you can see on the colour wash of these patients. So we've got, if we look at, there's 2 options here. So we've got MRI guided radiotherapy. This one here is a low field strength MR guided unit, and this one would represent something like the ViewRay system, which I'll talk about in a bit. On this side we have a higher field strength, 1.5 Tesla, typical of what we'd see for many diagnostic MR scanners, and this is consistent with the MR LINACs that have been developed by Elekta and Philips. So, and what you can see, I wish I could, how do I clear this? Let me clear all those. Yeah, there we go. What you can see clearly is this sort of increase in skin dose that you can see for these patients, and it's more significant for the higher field strength because that's what you'd expect as a result of this electron return force, this Lorentz effect. Now it's possible to sort of account for the impact of the MR beam, of the MR field on the radiation beam, but that's going to ideally require correction using Monte Carlo. So that has an impact in terms of computing power and availability for many people. Okay, so what I briefly touched on there was 2 different field strengths. Well, there was one example there that had a 0.35 Tesla MR field, and another one with a 1.5 Tesla field. And the general view of this is that higher field strengths yield better quality images. Okay, so higher signal to noise ratio, and that's traded off against this spatial distribution that we see and geometric distortion that will occur. So essentially what you have with field strength is a balance of better quality images versus better quality spatial accuracy. So there is a balance to be achieved. Now, as we'll see in a couple of slides, there is a way of trying to correct for this spatial distortion, but the ViewRay system, which uses a low field MR scanner, gets around this by using low field, and the argument there is that the quality of the images is perfectly adequate enough to, in fact they're very good, to be able to sort of use these for real-time MR imaging and intrafractional correction. But higher field strength produces much better quality images. Yeah, so field distortion. As we use bigger field of view, and that's obviously something that's necessary with radiotherapy, we get greater image distortion. And I'm not going to dwell too much on this slide, mainly because we're sort of running out of time, but I think the general principle here is that the bigger the field of view, the higher the field strength, the greater the extent of image distortion, and we have to be able to try and correct for that. And there are ways of doing that. That's beyond the scope of this session today. The other thing we need to consider is the fact that we need to use radiofrequency coils. How many people here have been into MR with patients and had to deal with adapting the use of coils? Just type away in the box, and I'll be interested to see if anyone's been involved with MR. There are issues with using coils in pre-treatment. Okay, Amy says yes. Go on, Amy, tell us a bit more. While you're typing away, I'll crack on. The main issue in terms of MR treatment units, when we're using these coils, these radiofrequency coils antenna, is that they have to be radio translucent, which those ones that are used in pre-treatment situations are not. So that it's required a redesign of coils, and they've worked with the producers and the manufacturers to be able to do that. Right, so let's look a little bit more at the design and the solutions for MR guided treatment units. And there are three solutions that are available. So the three methods are a bit like the Siemens Primaton system with the MR with the CT on rails. There is an MR on rails. So we'll look at that first. There is a system called ViewRay. Well, ViewRay is the manufacturer, and I forget what they call the system. It's a Meridian or something like that. But the ViewRay system, I'll talk about that. That's very different in the sense that uses a low field. So let me go back. MRI on rails. So we've got separate MR and LINAC. Okay, so it's not an integrated system, but we have a couch that's robotic and moves from one room to another. This is the system that's available in the Princess Margaret in Canada. Then we have the ViewRay system. The ViewRay system is an integrated system with 3 cobalt sources and a low field 0.35 Tesla MR scanner. And then we have the MR LINACs, which are 1.5 Tesla MR scanners integrated with a linear accelerator. Amy, were you going to say anything else before I move on? Oh, right, okay, work with MR LINACs. Whoa, okay, brilliant. hopefully you'll be able to contribute a bit more as we go through this then. What I was going to say before with regards to coils was that we've always had issues with using the appropriate coils, because coils are designed for diagnostic situations. So, and we have issues with those. So, for example, we would like to be able to use a head coil for our head and neck patients who might have MR as part of their pre-treatment workup, but we can't because of our beam direction shells, our immobilization devices. So we have to adapt what's already out there in terms of being able to modify body coils and use those instead, or integrated coils within the MR scanner. Right, let's have a look at these different solutions. So here we have the overall sort of plan for the MRI on rails solution. So we've got a purpose-built scenario of the here. So we can see here we've got linear accelerators, an MR scanner, and a couch that moves between them. Now, I think in a few weeks' time, I think it's the final week of the MRI, the IGRT module. We've got Laura Dalimonti from Canada who's going to talk about MRI guided brachytherapy for gynae and prostate patients. And she works in this centre and will talk a little bit more about how it works. So I'm not going to dwell too much now on this, we can come back to it. But you're probably familiar with the concept in that we have separate rooms and the couch moves, very much similar to the Siemens Primaton system. So patients scanned in the MRI on the treatment couch, decisions made on suitability, plan of a day, and the couch then moves to the linac room. And here we are with the usual sort of corporate photo. I think that's David Jaffray there, who's posing with his design. And so very effective. It's a nice simple solution to getting around the problems of integrated MR linacs. So, a quick question there at this point is, any possible limitations of this method? I'm going to pause for a minute, have a drink, and oh, sorry, Ben. That looks. I can't interpret that. Either your typing fingers have gone mad, or my screen's gone bonkers. O-W long R. Try again. Like you. Exactly. Laura's on the money there. Yeah. The patient will move. you have to have extensive immobilization. It's not the ideal solution. Yes. Yeah, the scan times, it's not, we all will know, or we should know, that MR scanning is not short. Has anybody had an MR scan? A few people saying yes. Yeah, yeah. And you'll know that it takes a long time. Well, minimum 30 minutes, probably 20, 30 minutes is a minimum. Sometimes it depends on the number of sequences. But yeah, it's time consuming. And with this system, yeah, you're relying on using the standard sequences that are available. Good point, Laura. I'll come back to that in a moment. Yeah, the sequences that are available. It takes a long time to do this. Laura's put, yeah, it's claustrophobic, noisy. Yeah, it is noisy. The noise comes from the gradient coils, that banging, grinding noise that goes on. Not pleasant. Yeah, difficult to get around that. And claustrophobic, yes, that's another issue, particularly in terms of for us, for MR guidance, in that what's the bore of an MR scanner? Something like 70 centimeters, where of course what we're used to with CT simulators are bores in the region of 85 to 90 centimeters.
So has significant limitations in terms of what we can do for immobilization devices. So our online shifts made to the patients whilst inside the MR. Again, that's the other perfect criticism of this method, is that it doesn't really allow for intrafractional correction. So anything that goes on, it's purely there to choose plan of a day, and that's it. What goes on during radiotherapy, we're stuffed. So the other systems, the ViewRay system and the MR-Linac, the Elekta solution, allow for some real-time imaging and to allow for some sort of gated approach to radiotherapy. This system doesn't. So there are limitations to the MRI on rails system, and well done for recognizing those. So the ViewRay system. Now, I'm a big fan of this. I think this is a lovely little approach to this. There are probably 3 or 4 of these in the United States that have treated a number of patients already. So there will be some clinical data within the next year or 2, I would hope, that we see in the literature. And the ViewRay system is based around the use of 3 cobalt sources with MLC correction and a low field MR scanner. And you'll see there it says a split magnet design. So that's the same principle that's used with MR-Linacs. Yeah, so Ben, yeah, similar to a Tomo design. I mean, the same sort of thing. Yeah, it's sort of a similar sort of thing in terms of how it looks. You can see that on this slide, and same for MR-Linacs too, really, to be fair. So yeah, we've got a split magnet design, so the beam can penetrate. The advantages of this system is that we don't have the same issues that we have with a combined MR-Linac. So the cobalt 60 provision is not affected by magnetic fields. Similarly, the cobalt 60 delivery does not affect the MR scanning. And the other advantage of this is that the low field strength means that we don't have significant issues with geometric distortion. The image quality isn't as good, but it is able to still produce good quality images. And as you can see at the bottom here, it acquires images at 4 frames per second. So we've got real-time imaging during the delivery of radiotherapy. We can see on this slide that we've got sort of good homogeneity. If you compare the field profile here with that without MR, and this is the difference over here, that's pretty consistent. Okay, so the MR field has very little influence on the delivery of radiotherapy using the cobalt beams. Similarly, it has, compared to MR-Linacs, relatively small differences at tissue-air interfaces. So if we look at, oh, it's the wrong colour. Don't know how to change that. Oh, I do. Here we go. No, that didn't work either. There and there. You can see there that you don't get the same degree of electron return effect as you do with the high field strength. Okay. So I've already talked about these. In terms of disadvantages, advantages. Oh, right, okay. Why have I got disadvantages? Okay. So disadvantages are probably as you would expect, in the sense that we've got cobalt sources there. So I'm sure, are there people here that have worked? I know Ros has, because if Ros is still with us, both Ros and me have worked on cobalt units in the past.
those that have know the issues with cobalt units. Sorry to remind you, Ross. But yeah, these decay, a half-life of 5¼ years, so they have to be replaced. And also, over a period of time, the treatment delivery time becomes longer. Right, so the MR-Linac solution. So this is the solution that was developed out of Utrecht in the Netherlands, and combines a 1.5 Tesla scanner along the lines of the Philips MR scanner and a Elekta Linac. So we can, what can we see on here? Well, it's the same sort of principle in that we have a split MR scanner, because obviously the radiotherapy beam has to penetrate through there. Let's get back to some black. What else is there to point out on here? So here we've got the MR scanner in here, and the gradient coils in green. Okay, the Linac, which is a standing wave linear accelerator, here in red. And what you can see in light blue around here is a sort of toroidal opposing magnetic field. And the purpose of this is to minimize the fringe field effect of the MR scanner. For those that have been in an MR scanner, you will know that the strength of the field is still quite significant, some distance away from the scanner itself. That's a bad thing with an MR Linac, and you want to ensure that all the key parts of the Linac are away from the high field strength of this 1.5 Tesla magnet here. So there's an opposing, and we don't need to go into the physics of this, but we've got this toroidal opposing magnetic field that keeps all of these sort of sensitive parts of the Linac safe and working correctly. So this is not a new concept, as you can see here. This is dated 2008. In fact, the prototype and the feasibility study was done 3 years before this, in 2005, and led by Bas Raymakers at Utrecht. And that's what you can see here in this diagram, in this picture here. So you can see what we've got is a sort of miniature Linac on a wooden table on this side, and the MR scanner over on here. So this showed that this was proof of concept that this could work. I've already talked about issues of radio frequency, and I've already talked about having this gap in the magnet to allow the beam to penetrate. Cracking on. So what we can see here is how good a quality the images are. So with very high resolution images with our MR Linacs. These are superb images, and you can probably start to appreciate now the benefit of MR guidance for certain categories of patients. Things that we would be able to see with this that we can't see with cone beam CT. And I think yes, so what we can use with the MR Linacs, we can get real-time imaging, not quite at the same rate as we can with the ViewRay system. So this is half the rate, so 2 frames per second. Now this was originally a slide that showed this in real time, so 4D showed these things moving, but yeah, so you can see real-time movement here. The advantage of the ViewRay system, I'm not as sure with the MR Linacs, but certainly with the ViewRay system, you can automatically correct. You can automatically correct in the sense that the beam will be on and off. So if a defined target in the ViewRay system moves outside of a predefined margin volume, the beam will turn off, and then it will turn back on when it's in place again. So that's the beauty of that. You've got perfect, and the same thing theory with this because of this here. And the same thing with an MR Linac is that you've got real-time intrafractional correction for movement. So this is a slightly dated slide now, but yeah, you can see, give an idea of what these look like. So as I said, there's certainly these been installed in the Marsden in the UK and the Christie. I'm not sure of anywhere else, but it could be. There's probably more. But this is what's going on in Utrecht, and they're further along than anywhere else. So, where are we going to in the future? Well, I think the question I'd like to set for the rest of this session is this the future? Are we moving towards MR-guided Linacs? Clearly, it's not going to be a solution to everything. There are issues. But is this something... certainly not in the image. Yeah, I think you're right there, Ben. Although, yeah, it depends on what happens in the Christie and in the Marsden, I suppose. Once we start to get some data, yeah. But yeah, we'll have a discussion about this in a few minutes. And where is it going to offer benefits? And this is the final slide on here, which I hopefully will lead on to some discussion. Now, some of the original feasibility studies that were done and looked at, not using MR Linacs, but using repeated MR scans throughout treatment. So these were particularly for cervix and for prostate. The general conclusions from those studies were that the factors that had the most impact were what you might expect them to be. How mobile the CTV was. So does it move a lot during interfractionally and intrafractionally? If so, then if it's soft tissue, then the MR will show us, then clearly MR guidance is going to be a benefit there. Also, organs at risk. So if organs at risk are close to our CTV, and they're likely to move around as well, so for example, again, cervix, prostate, all those sorts of things, then again, MR guidance is suggested as being very beneficial. Also, if we're working with small margins, or with immobilization that isn't, I wouldn't say isn't adequate, but isn't as perfect as it might be, I suppose. That might be another issue where MR guidance is of value, but clearly it's not going to be suitable for all, and there are going to be a number of patients who are contraindicated as a result of, at the simplest level, having ferromagnetic materials within them. So, in general summary, it's of most benefit when there are close organs at risk to our planning target volume, and the position and shape of the CTV is likely to be quite different from our pre-treatment or expected situation. That is where MR guidance is probably of greatest benefit. And that's where I'd like to finish this. That leaves us 15 minutes to sort of get into some sort of discussion about, is this going to be the future, irrespective of the funding issues, or is it a solution to a problem that we can solve in different ways, or is it a solution to a problem that, you know, isn't of greatest concern to us? So over to you, and I'd like to hear your thoughts about MR Linacs. Okay, so as you type, I'll try and read how does it work with our 6 degrees of freedom in terms of correcting for EG rotations? Is it fully adapted? That's a good question. I mean, there are, you're probably thinking here of the other solutions, like sort of the KV imaging with Exact Track, and there are other ones as well. There's optical. What's the other one? Not optical. With the transponders. Calypso. Calypso is, yeah, that's a slightly different solution, but yeah, the Exact Track uses 6 degrees of freedom where it sort of automatically correct for position. In theory, yes, you can do that with these. That's the whole point, I think, of these MR-guided units, is that they do allow for fully adaptive radiotherapy. Can they account for organ motion? Yes, definitely. That's, yeah. If you have a look online at the go to YouTube or go to some of the manufacturer sites. So if you look at the ViewRay
information, yes, you are going to. It will account for organ motion. As for lung, that is that's an interesting question there, because yeah, lung, you've got significant issues with scatter. So there are, as I mentioned earlier in this session, there's these problems with sort of dose planning and expectations at tissue air interfaces. Yeah, exactly, tissue air tissue interfaces. So whether that MR is perfect for lung, it's a good question. I'm not sure. Can you track with MLCs too? Yes, that's a good question, Roz. Certainly the ViewRay system. I can't speak for the MR Linux, but I've been to a couple of presentations and talks with the guys from ViewRay, and yeah, that has sort of MLC guidance and tracking within there. That's yeah. Say I think leaving lung aside and probably breast. I mean, because obviously there are other issues with breast in terms of skin dose, exit beams. For these, yeah, you get considerable skin dose with exit beams with MR Linux and treatment units. Not so much with the ViewRay system, certainly more with MR Linux. But yeah, liver, that's a good one. Yeah. Patrick, I can't answer that, I'm afraid. I don't know. That's a very good question, and I can't answer it, I'm afraid. Can you do rapid arc on ViewRay system? Not really, because the cobalt sources are in a fixed position. So it's no, rapid arc wouldn't work like that. No. How long would it take to treat using MR Linux and ViewRay? Again, I'm not the best person to answer that, because I've never actually seen one. But certainly with the ViewRay ones, it's going to depend on the clinical situation, I think. Certainly, so MR Linux, another thing to consider about the MR Linux, by the way, is that the dose rate for the MR Linux is something like 350 centigrades per minute at the isocenter. And the isocenter for the MR Linux is not 1 meter from the source, it's 1.5 meters. No, sorry, it's 350 centigrades per minute at 1 meter. But the isocenter is at 1.5 meters. So yeah, treatment times are longer. What we've got here, pancreas could be a good one for MRI. Yeah, pancreas, liver, yeah. Soft tissue, where soft tissues, where they're quite difficult to see on cone beam CT, definitely. So Laura makes a good point here. Interesting verification treatment time. Yeah, because it is real-time imaging. If you're using these, then yes, it could be certainly where it's the ViewRay system, for example, which is sort of almost like a gated system. It automatically turns the beam on and off. That's the general issue with verification. We want automation. How does it affect dose? Okay. How does it affect dose? Well, yeah, skin dose is going to be is higher. If you with planning systems, if using adaptive systems, if using Monte Carlo, I guess that's incorporated.
try to click through these, I'm starting to lose track. Julius, what's the maximum field size? That's a good point. Yeah, you don't get the normal maximum field size on an MR Linac. What's the maximum? 40 by 40 on a normal Linac, less than that actually. What we're looking at for a MR Linac, it's in the region, I think, of something like 24, maximum field length is 24 centimeters because of the split, the gap in the magnet. So it's considerably smaller, but still bigger than we would normally need. Very beneficial for anatomy that can be difficult to ID from the eyes. Yeah, absolutely. Yeah. Vivian, it does seem to be in the future for many sites. MRI mostly used for staging, in some cases planning. That's actually, the planning issue is something I didn't really touch on in this because I think we sort of devoted most of that to the pre-treatment stuff and whether, you know, how feasible it is to plan on MR data alone. There are algorithms that can convert MR data into modified HU units and house flow units, but I don't know much about that. Kira, is the radiotherapy technique going backwards with these machines? No IMRT, but advanced imaging. Yeah, it's sort of, yeah. Isn't that the whole point of, you know, sort of imaging is now, you know, image guidance is the expected standard of care. But that's the key question here. Is MR imaging necessary? I mean, that's what we don't know. There is no clinical data at the moment, I think, that, as far as I'm aware, that demonstrates that MR guidance leads to significantly better outcomes than using other forms of imaging. So I suppose this is the point I was making earlier. I don't know the answer, but you know, it's a question to ask. Is it a solution to a problem? Is it a sort of a sledgehammer to crack a nut? Is it what we really need? And we don't know until we start to see whether MR guidance offers significant advantages, statistically and clinically significant advantages over other imaging systems. We shall wait and see. But clearly there is a commercial interest and benefit to these because people are looking at these. Manufacturers want to sell them. In an early PowerPoint, I think I read that MRIs have an inherent geometric distortion. Yeah. Yes, it does. Yeah, I'm not sure if you caught this earlier, but there are a few things that influence the extent of geometric distortion. And they include the field of view, which for us in radiotherapy tends to be quite large. So the larger the field of view, the greater so the further you are from the center of the magnet, the greater the center of the magnetic field, the greater the geometric distortion. So the greater the spatial, the poorer the spatial resolution. And where was that? There is the strength of the magnetic field. So the higher the field strength, the greater the extent of that geometric distortion. And also there are other inherent things that will influence that. So how stable the magnetic field is. Now that's an issue as well with MR Linacs, although you know generally they tend to, you know, the magnetic fields, they've designed these so they are very stable, but they're not as perfectly stable as diagnostic quality scanners, is my understanding, but we're talking about very small amounts. And also there's, you know, sort of patient inherent things that will affect the magnetic field and therefore affect the spatial distortion as well. Ross, isn't there a comparison somewhere of prostate volume size when marked up on CT and marked on MR? Yeah, definitely. Yeah, that's quite old, that, Ross. Yeah. MR generally leads to smaller tumour volumes, CTVs. It's very difficult to differentiate between the edge of the prostate gland and the extraprostatic fat and vessels that are around it. So, when you look at a CTV, at a CT scan, even one that you can manipulate the window level and window width, it's quite difficult for clinicians to be able to clearly see where the edge of the prostate is. It's much better on MR, so hence the reason for CT-MR fusion for prostate patients. So MR is the gold standard for planning CT. T2 weighted MR scans show on a T2 weighted MR scan you can see the prostate very clearly, and other sequences, other MR sequences will allow you to see different parts of the prostate as well. So you can see different lobes, different parts of the prostate. So it's the most effective way of delineating prostate by far. And it certainly improves inter and intra-observer variability. As you say, which is really right? MR is right. CT overestimates. CT is needed for electron density. Yes, definitely is. There are ways around this for some techniques. If we're just talking about the use of MR for planning, for certain techniques, you can just simply use bulk density correction. So instead of using a pixel by pixel correction in the planning based on the electron density values from the Hounsfield units, you can ignore all that and you can say that's bone, I'm going to give that assign that a density. That is air, I'm going to assign that a density, and that's all soft tissue, and I'll assign that a density. And that will give you an adequate, is probably the best word I can use there, dose distribution. I suppose it depends on the algorithm that's used as well. If you're doing this based on a sort of a fairly simple convolution algorithm, then that, if you do a bulk density correction dose calculation, that will be pretty accurate anyway. Ideally, you can sort of, if there is an algorithm exists that will allow you to convert intensities that you see on MR into Hounsfield units, then you can plan from that. But that's still fairly new, nothing clinical there. But yeah, you do need CT. Okay, we're approaching the end of our time. Has anybody got any other questions or comments that we'd like to make about MR-guided treatment units? Personally, I'm going to sit on the fence with these. Thanks, Pavnish. I think like most people, I'm going to wait. Good question, Ben. I don't know. I imagine that they will be, or they'll be trying to catch up. It's a commercial venture, but I don't know. But yeah, I'm going to, like most people, I think I'm going to sit on the fence. I'm going to wait until there's some clinical data that shows that this is having an impact on outcomes, and those outcomes might be survival and they might be on toxicity. But I'll wait to see. I think those centres that are delving into this have a vested interest, possibly have a vested interest, or are well funded. We'll wait to see. We can learn a lot from these. Then, good question. When can we expect feedback on our eTivity 1? It's not off topic. It's a fair question. Middle of next week, I hope, if that's okay. We'd like to get this done sooner. But Mark is on leave for the rest of this week. Alex is in. I'm completely snowed under until Monday. Pavnish, did I Did you get my email? I don't know. I don't recall one. I'm sorry. I'll look back. Okay, so first thing tomorrow, I'll go back through my emails. If I've got one, I'll reply. Okay, that's fine. Are other activities part of the final essay word count? Okay, right, Vivian, that's a good question. It's not really an essay as such, but as you'll have seen from the information I've posted on the other activities, they are all going to give you something that you can use in the web folio. So everything that all these activities will, email notes. Okay, Julius, I'll check my email. So I've been absolutely snowed under these last couple of days and I've been out and about. But I'll have a look and I promise I will get back. I'll check through those and I'll get back tomorrow. Just going back to the question from Vivian, essay word count. Yeah, so these activities, these are things that you will be able to use in your final summative assignment, the web folio, bits that you can use. And the beauty of this is that before you submit, we'll be able to offer you some formative feedback on them. They're not going to constitute all of the final web folio, but a significant proportion of it. So, you know, if you participate in these activities and do them, that you have done a great deal of the final assessment that's expected for the module. Ben, hasn't been anything posted about other activities today? Yes, I did. I posted that, and that's if you go to the IGRT workspace, there is a resource there under resources, and it's got the dates and the topics for each of the activities. I think I also posted something under the bulletin board for this week with a picture, an image of those. Yeah, Vivian's got that. It's at the bottom of the bulletin board. Okay, folks, any other final questions before we call it an evening? Thank you, Rachel. I hope it's been useful tonight. It's something that's at the forefront of our profession now. I'll wait for. I'm not sure what Ben was typing now. Type it again, Ben. Okay, right. MR treatment units. So sort of these are sort of the now of what tomotherapy was a few years ago. So, you know, now we're sort of looking at whether these are a good solution. But yeah, Laura says it's definitely there. So if you go to the bulletin board page and scroll down, there's a picture under there that has everything that you'll need. But thank you for participating tonight, people, and hopefully you can take part in the tweet chat tomorrow night. Tweet chat tomorrow, we're going to be focusing on some of the future training issues that we might face in terms of how we develop the workforce, and both at pre-registration and post-registration. So something that most of you will be interested in. Publish. Is it a specific time? Is this the tweet chat publish, or is this the tweet chat? Yeah, 7 PM, usual time on Thursday. Okay, thanks everyone. Right, I'm going to get my tea. If I don't see you tomorrow, I will see you next week. Okay, enjoy your evening.